Hello to both Rational Wellness Podcast listeners and viewers of the monthly Functional Medicine Discussion Group. So this is a recording of our monthly Functional Medicine Discussion Group meeting. And today the topic's on small intestinal bacterial overgrowth with Allison Siebecker. And normally I just put these recordings on my YouTube page, Weitz Chiro, but I've decided to add this to the podcast feed as well. There's some really great clinical information, and I'm sure educated consumers would enjoy this as well. It's really packed with lots of educational pearls and clinical concepts for being able to treat patients with functional gastrointestinal disorders, specifically irritable bowel syndrome and small intestinal bacterial overgrowth. Normally for the podcast, we usually keep it to about an hour, but this the meetings often go for a couple of hours, and so this recording is for 2 hours. So just keep that in mind. But really a lot of quality information here. So I think that you'll enjoy it. So anyway, so now I'm going to give the intro that I normally give at the meeting, and then we'll hear from Dr. Siebecker to start. Unfortunately, the first part of her conversation, the first minute or two, didn't get recorded. So just keep that in mind. So welcome everyone tonight to our Functional Medicine Discussion Group meeting, which normally takes place in person at the Santa Monica Library. And this is our first online meeting. And perhaps some of you are joining us for the first time because you don't live in Southern California, and this makes it more convenient. But even if you do live in Southern California, given the traffic situation, online meetings can be very convenient. However, one of the reasons why I started this functional medicine discussion group approximately 3.5 years ago was partially to bring the functional medicine community together so that we can network and collaborate and learn from each other. And we've been very successful in building a lot of lasting relationships that way. I've been organizing these meetings and donating my time and some of my staff time. And so my ask tonight is for each of you who are listening to please subscribe to my Rational Wellness podcast. And if you enjoy the podcast, to give me a ratings and review on Apple Podcasts. And of course, we've had lots of great interviews on digestive health, including several with Dr. Allison Siebecker. And of course, recently we've had a number of interviews about the COVID-19 crisis because we're presently in the midst of this coronavirus pandemic. But tonight we're not going to talk about the coronavirus, so you can think of this as a way to get away from all the COVID-19 coverage. Next month, we have Dr. Pimentel scheduled to join us on May 21st. Thursday, May 21st, and we'll have to see how it goes, but I suspect that may end up needing to be an online meeting as well. Anyway, our topic for tonight is small intestinal bacterial overgrowth and how best to understand the mechanisms, the latest diagnostic methods, and to get some new insights on which integrative treatment strategies work and don't work. We're so grateful that our special guest is Dr. Allison Siebecker, the Queen of Sibo. And Dr. Siebecker now has a wonderful practitioner training program for learning how to treat patients with Sibo. For any practitioner who wants to sign up for her Sibo Pro course, if you use the discount code BEN and you sign up within the next 2 weeks prior to April 17th, you will save $700. And I can tell you, you'll really learn a lot if you take this course. Dr. Allison Siebecker is a naturopathic doctor and acupuncturist, and she's extremely passionate about education. She specializes in the treatment of small intestinal bacterial overgrowth, and she teaches advanced gastroenterology at the National University of Natural Medicine in Portland, Oregon. She has the most incredible resource for research articles and information about Sibo on her website, which is siboinfo.com, which is also where you can find information about her Sibo Pro course. So tonight, I'm hoping that what we can learn are some of the latest developments into the research around Sibo, as well as gain some new insights into how we can understand, diagnose, and treat our patients suffering with Sibo, and while also learning how to reduce the frequent recurrences that tend to occur. So the first question for Dr. Siebecker is, can you start, please, by defining what is Sibo and what are some of the most common symptoms?
Abdominal bloating, abdominal pain or discomfort, constipation, diarrhea, or a mixture of the two, and then a lot of other symptoms. The symptoms come from food, either triggered by eating or drinking, taking substance in. And carbohydrate food intolerances are most common, not as much meat or fat. Protein or fat. It can happen because people can have more than one thing wrong with them at a time. In fact, all of our patients do. And also there could be nausea, acid reflux, food sits in the stomach, won't go down, gastroparesis. There can be anxiety, brain fog, and depression. Anxiety's most common, more so than depression. Brain fog's pretty common. Fatigue. It's just a lovely situation. So I will say, as I'm just defining it, that is one of the new developments in a paper that just came out in January, giving guidelines on Sibo from the American College of Gastroenterology. I can actually show you the article on my screen. I just opened it so I can show it to everyone. Let me share my screen. I'll do that. This is what the article looks like. ACG clinical guideline. There's a new definition now that they've put forward in this paper, which I really like. And they describe it as, I'm not sure exactly where they do this nice definition. Oh, here it is. They define it as a clinical syndrome. That's new that they're doing that has to have symptoms caused by the bacterial overgrowth. And the bacterial overgrowth is proven with a test. So what this means is, I really like that they've done this. This is Dr. Pimentel Rao and a few other doctors. They've made it so you have to have both a positive test indicating the physical overgrowth of bacteria and symptoms, and that those are related. I mean, sometimes we don't know, right? We treat the Sibo and maybe the symptoms don't get better and we're like, okay, I guess those symptoms were from something else. But I like it because we've always known you can't diagnose Sibo by symptoms alone because the differential diagnosis is mammoth for bloating, constipation, diarrhea, or abdominal discomfort. Like I have a differential diagnosis chart with like 45 conditions that can cause those same symptoms. So you can't diagnose it by symptoms alone. But on the other hand, I don't like to treat a test, right? So if there's no symptoms or 90% better in the symptoms, but there's still a positive test, I don't care. Like I don't go after that. Now, other people might feel differently, but where I find that comes out the most is in our patients who are anxious and they're really like, I don't know, they're regimented and they want when their symptoms are like better, 90% or more better, they want a repeat test, right? I'm sure a lot of you have experienced this. The repeat test might show still a slightly positive Sibo, and then they just want more rounds of antibiotics or herbal antibiotics, but they have like no symptoms, and so like they want to treat the test, and it can be frustrating. So what I like now is I have an article from the American College of Gastroenterology that I can show to the patient and say, no, we don't do that. You do not have Sibo anymore because you don't have symptoms. You know what I mean? But yes, they might still be anxious, but can we for sure say that that's the Sibo? I will say that very often the anxiety does go away when the Sibo goes away. But symptoms may take a couple weeks to fully clear once the bacterial overgrowth is gone because damage needs to heal. The enzymes need to come back. The leaky gut needs to heal. It takes a little while to bring the cytokines down and such. So anyway, I just rambled on and on with that question you asked me.
No,
so
that's great. That's great. So, what is the difference between Sibo and IBS? first of all, what is IBS? Are we supposed to think of SIBO as one of the main causes or the cause of many patients with IBS, or is SIBO a condition in and of itself, or how should we really think about this?
Well, I will just share my perspective, from my clinical experience and all my reading, and others might not feel the same, but what I feel is that SIBO is an underlying cause of IBS. Let me just explain what is IBS. Explain what SIBO is. IBS is diagnosed by symptoms, by the Rome criteria. So we now have, I believe we're on Rome 4. I think Rome 5 is in the works. But so like they keep meeting and giving us diagnostic criteria of the kind of pattern of symptoms, the length of time, et cetera. And what's been going on over the years is that what most of us have known IBS to be, the Rome Consensus Committee is changing that definition. I don't know if you've been following it, but they're making it used to be much more about bloating. Oh, really just how I described it, bloating, the bowel movement changes, and some pain or discomfort. Now the emphasis is on the pain. They've actually taken the bloating out of the definition. And you may or may not know that most of the doctors who sit on this consensus committee don't agree with the guidelines. There's actually been one, if not more, articles published on this. Actually, Dr. Pimentel, you can ask him about it when he comes next month. He actually surveyed his fellows and said, do you agree with these guidelines? And most all of them said, no, this isn't how we diagnose SIBO IBS in our clinic. We pretty much go by Rome 2. And they were all on the committee. And so it's so then I asked Dr. Pimentel, is this the kind of thing where, you just get a whole bunch of people in a room, they have to come to consensus, and no one what no one thinks is represented by that consensus? And he's like, yeah, pretty much. So just keep that in mind, So anyway, it is diagnosed on symptoms. It's been considered a diagnosis of exclusion also, meaning that you needed to have ruled out IBD, colon cancer, done a colonoscopy, and celiac, maybe done an endoscopy or celiac serologies to be sure you can call it IBS. That has been in dispute for a couple years now among the experts. So some of the experts are saying you don't need to do that. It's not a diagnosis of exclusion anymore. You can diagnose it just on Rome criteria, et cetera, et cetera. So, there's debate. But anyway, what we know, now pulling back for a second, what we know is...
So just so we can clarify, in terms of symptoms, are there differences in the symptoms between IBS, or are they the same?
IBS and SIBO, they're the same.
Yes. Okay.
They're the same symptoms. So pulling back, what is IBS? It's caused by different things. All it really is when somebody has those digestive symptoms. So in my opinion, what often happens is people, gastroenterologists or whatever, are not looking to figure out what's causing those symptoms. So people are often labeled as having IBS by the symptoms, but you have never found the cause. It could be a cajillion things: yeast overgrowth, parasites, SIBO, and, hypothyroid, on and on and on. So in my opinion, most of what's diagnosed IBS is really something else. So you can call anything IBS if they have those symptoms, but now let's figure out what it is. So what's gone on is that there's been a large group of people where they haven't figured out what it is. And now we've realized a large group of people really have SIBO. So the stats are about 60 to 70% of IBS is due to SIBO. So now let's go a little deeper. What causes SIBO? Now that could be a huge discussion. So just, very briefly, there are all kinds of diseases. There's surgery and anatomical circumstances that can cause obstruction and backup of bacteria. And really any disease or circumstance, there's drugs that can cause a slowing of the small intestine motility, or like an obstruction in the small intestine, or like a segment or pocket in the small intestine that's not subject to the normal flow, where bacteria can build up, like blind loop syndrome, like anatomical blind loop, or like diverticulosis in the small intestine, which is not that common. Those are the physiologic underlying causes. And so then the causes would be any disease, drug, or circumstance that creates those. So, we can always go deeper. So something that a lot of people get their knickers in a twist about is, SIBO is secondary. Like, well, yes, of course, something's causing the SIBO, and then the SIBO causes the IBS. And to me, it's not unlike anemia. Like, anemia is a condition, but something's causing the anemia, and then the anemia has symptoms that it causes, So I don't see why that has to be such a huge thing. I think maybe when people get all upset about that, I think what they're trying to do is indicate, please don't leave it right there at, I found SIBO, that's all, that's it. We do want to look for what's causing that, because 2/3 of cases of SIBO are chronic and relapsing. And this, I believe, is mostly due to the underlying cause that is still there. However, 1/3 of cases are not chronic. They don't relapse. We can treat them and it resolves not to come back again. And so in the 1/3 of cases, we don't need to be concerned about what the underlying cause was, because it's gone. But for the majority, we have to think about it.
Now, there's a number of mechanisms that are normally present in the gut to prevent bacteria from overgrowing in the small intestine. So of those mechanisms, we have the motility, which you mentioned already. We have hydrochloric acid secretion from the stomach. We have digestive enzymes. We have bile production. We have the ileocecal valve, which prevents the bacteria from growing back up from the large intestine into the small intestine. Which of those do
and the
you
immune
think,
system.
And the immune system, right? The immune system in the gut, which sometimes we measure secretory IgA on a stool test as maybe one way to indicate that. Could you rank those in order of importance?
Yeah. So number one is the migrating motor complex, which is the motility of the small intestine during fasting. So in between our meals, the migrating motor complex comes out. It's a sort of a strong sweeping motion, sweeps away any food debris. It sweeps away bacteria. It's Dr. Pimentel always says it's like washing the dishes after you eat. It comes with some bile and some enzymes, so that's kind of like the soap, and just scrubs it and then sweeps it. And that is when that fails, that's the number one physiologic underlying cause of SIBO. Dr. Pimentel has said he believes about 80% of SIBO is due to lack of motility in the small intestine, migrating motor complex not working well. Next would come the normal anatomy, the normal structure. When the anatomy, because obviously our anatomy is meant for things to flow through and leave. When that gets altered so that there's obstruction or these segments, that also will cause SIBO. That's number two. Now, some altered anatomy problems are not as much true physiologic underlying causes of SIBO. They go a little bit lower in ranking, like absence of the ileocecal valve, or it not working, maybe it being a low tone, right? So it's stuck open, ileocecal valve syndrome. And also like a fistula. If there was a fistula from the large intestine to the small intestine, these will increase risk. But we have studies done most often on children who've had their ileocecal valve removed that don't get SIBO because they have the migrating motor complex still working. So what it appears is that migrating motor complex and in sort of an open, intact, normal anatomy in that way will compensate for the loss of the other protections, also including hydrochloric acid. So then I would say number three would probably be the immune system. I'm a little confused as to where to rank that, because while I think it's very important, and there's a high rate of SIBO in immunodeficiency, frank immunodeficiency disease, I've read some articles that said that when you have frank immunodeficiency disease, you have a lack of motility that comes with it. And so I'm unsure. But I guess the reason I feel it has more importance is because we see so many SIBO patients that have multiple chronic infections. They have yeast overgrowth, maybe they have Lyme, or they have just a lot of, they have a viral load. It sort of all comes together, so I'm a little confused where to rank it. So currently I rank it number three. And then I would put hydrochloric acid next. And then below that, I would put bile and enzymes, mostly just because not much research has been done on it. So I can't tell.
We've been having a great discussion, but I'd like to take a minute to tell you about the sponsor for this episode. I'm thrilled that we are being sponsored for this episode of the Rational Wellness Podcast by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative, a dynamic resource for practitioners to learn with and from leading experts and fellow clinicians. I am a subscriber, and if you include the discount code WEITZ, WEITZ, you'll be able to subscribe for only $99 instead of $149 for the year. And now, back to our discussion. Do you think that the bacteria that are present in Sibo, for the most part, are overgrowing from the large intestine? Or do you think they're coming down from above? Or they were there in the small intestine and they've just grown more?
Okay, I'm so glad you asked me this because there's some brand new information and now I get to talk about it. So Dr. Pimentel last year at DDW presented.
That's Digestive Disease Week, right?
Yeah, that's the big gastroenterology conference they have every year in May or June, usually in May. It rotates locations. And, these researchers work all year long to prepare to present their findings at that spring conference. So anyway, last year, what he presented was that he and his team actually developed new techniques for taking fluid samples, basically culturing or deep sequencing in the small bowel. And they presented those findings because there's been a lot of problems with trying to do those tests with culturing. There's a lot of problems, contamination, being able to reach, getting enough bacteria or enough juice. So anyway, they published that paper, actually came out in December, but they presented it last year. Then they used those new techniques, and what they did was they did microbiome sequencing of the small bowel. That has not actually ever been done. So the genome project, the microbiome sequencing project, never sequenced the small bowel. They used stool, and that only actually indicates like the left large intestine. So they sequenced it, and so they did it in obviously normal, healthy people, so we can know what's normal, what amounts are normal, where they actually used special techniques to get the endoscope all the way down into the top of the ileum. They couldn't always do it in everybody. It's very difficult to do that because, the small intestine is this coiled length that goes 20 feet long. By the way, I observed with Dr. Pimentel, and I watched him do a colonoscopy once. And I actually, I'm not a gastroenterologist. I don't perform those tests. I don't know if anyone here is, but boy, did I get a sense of respect for the actual physical art of getting the scope where it needs to go. Anyway, so then the final thing they did was they then did that microbiome sequencing on SIBO patients, and then they could compare it to the healthy. And that has not been published yet, but I was able to watch that presentation at DDW. So anyway, what's really interesting to me is that what they found was that the bacteria that are most overgrown in SIBO actually do live in the small intestine in normal, healthy people, just in a very small amount. Now, these bacteria, so the main players were Klebsiella, E. coli, Aeromonas, TM7, and one other one, but mostly E. coli and Klebsiella. These are the most overgrown bacteria in SIBO amongst different patients. And by the way, this would be for the hydrogen type. There would be Methanobrevibacter smithii there if it was a methane dominant patient, and there would be sulfate producing bacteria if it was hydrogen sulfide. They didn't report any of that. Maybe the people I think actually the people they tested were hydrogen dominant. So anyway, these bacteria have been called coliforms for the colon. meaning that they are bacteria that normally live in abundance in the large intestine. But now we actually know from his study that they normally live in the small intestine in small amounts. So it is my personal belief that the bacteria in Sibo are mostly just overgrowing from what was there in the small intestine themselves. And I actually had a feeling about that from all these articles I've read. So many articles back done on people with obstruction by surgeons in the 20s and the 60s. And I just had an inkling about it. And I was never sure that a lot of experts say it's bacteria migrating up from the large intestine. And I feel less sure about that now because maybe it's really just these bacteria. So when you have Pimentel next month, ask him what he thinks. Does he think that, It'll be really interesting to see what he says. And it could also be, we certainly know that there's upper respiratory tract bacteria shown overgrown in Sibo, but they're not the main players. They're not the most overgrown. So, and that could have been instrument contamination.
Yeah, I remember 2 years ago when he spoke at our meeting and he described his autoimmune concept for how Sibo gets started. And he talked about the damage to the migrating motor complex. And then he talked about a stream where that instead of flowing quickly, that you start getting a backwash. And so he clearly talked about, the bacteria growing backwards from the large intestine to the small intestine, but he might not think the same thing now.
Or he might, and I might not be right. This is just my thinking, right? From reading his studies. So
yeah. So let's see. We've had some questions come in. There's a couple of questions about testing. Why don't we go into testing for Sibo, and then maybe you can cover, the accuracy of testing and, what do we know about the most recent ways to interpret the test in terms of hydrogen, methane, and are we ever going to get the hydrogen sulfide version?
I'm sure we are. These things always take longer than one thinks. So I'm sure it'll come out. I don't know when. I haven't, I actually just got an email this morning from the head of that lab, but he did not say anything and I didn't push. So I'm sure they'll let us know as soon as it's ready. It'll be coming from Gemelli Labs. That's one of Dr. Pimentel's labs. Anyway. Okay. So for testing, would you like me to just explain how I interpret
Sure.
Interpret the test.
And we're talking about the lactulose or glucose Sibo breath test, right?
Yeah. So I prefer lactulose because glucose is predominantly thought to absorb within the first 3 feet of the small intestine. Now, we do have some of our, experts saying it can go lower. So I actually started doing some side-by-side split testing of glucose and lactulose, and I don't have a full complement of results yet. I have, something like 8 results, and I can tell you only one of them matched up so far. And so, just in that, you have to take it with, it's only a small amount of comparisons, but so far, it's validating what I had been taught. So I prefer lactulose because it goes through the whole, it's non-absorbable. It goes through the whole small bowel and basically allows us to test the entire organ that we're trying to assess. So that's why I like it. There's been an argument that glucose testing is more accurate. Actually, what Dr. Pimentel found, he looked at culture deep sequencing and lactulose breath testing. When he did that deep sequencing, he found lactulose breath testing perfectly correlated with the deep sequencing because of these improved techniques. Now it's showing the matchup. So whereas we didn't have these techniques, we had insubstantial techniques. So anyway, I feel very good about lactulose breath testing. I've used it all this time. I have felt confident in it. So what I like to do is I like to do a 3-hour
By the way, for those of us who aren't aware, this test has been much maligned and critiqued over the last several years.
Always. There's always been a fight between experts between glucose and lactulose. The Italians,
or even whether the breath testing has value or
whether it even has value. And actually, I think the new studies, the new techniques and the new studies Dr. Pimentel did are probably going to answer that. Those, of course, need to be duplicated by other people. So I have a feeling we're going to see this controversy begin to die down now that we can have accuracy. But yeah, there's been like the Italians only like glucose, and then, Pimentel here in the US likes lactulose, and then you just see them fighting it out in the articles. And actually, they for any of you who are watching at the New Orleans SiboCon, we had the audience. I was moderating a panel where we had the speakers into glucose and the audience into lactose, and like the audience and the speakers were like fighting, friendly fighting. So anyway, it's like, whoa. So anyway, I'll just share what I like. You can do whatever you want. So I like a 3-hour lactulose, and I like it to have 10 tubes. I only learned recently that Genova is using an 8-tube test, I believe, where they're spacing out the...
You go 20, 20, 20 for the first 2 hours, and then 30 minutes apart for the last hour.
Yeah. Now, the reason that this matters to me is because we don't have hydrogen sulfide testing yet. And so until we get that, and if, unless you completely switch and you're only now going to use the 3 gas test when it comes out and you're going to switch to that lab, then I would recommend a 10-tube 3-hour test, because we need good assessment of the 3rd hour, which is traditionally the large intestine, to be able to assess for hydrogen sulfide. So why don't I just take that one on right now and explain it?
By the way, I've always used Genova. Which labs, is it Aerodiagnostics, or which labs offer the 10 tubes?
Every lab except Genova and Commonwealth, I think, only goes to like 105 minutes or something like that. But they might have a 120 minute. Wait, let me just look. I have it. So I have it on my website. I don't have it memorized. Let me just look. So I'll share my screen so you can see what I'm looking at. Here we go. So this is just on my website under resources testing. So here we are in the United States. We have, let's see, Commonwealth. What does Commonwealth do? They do a 2-hour and 15-minute test. Okay, so that's all they do. So they don't go to 3 hours anyway. And then Genova, now I just found out, does this 8-tube test. So all of these labs do the 10-tube test.
Interesting.
3-hour 10-tube test. I'm sure there are more labs, whenever, like lots of doctors' offices will buy a machine and then begin testing and actually sort of open up for business. And so I bet there's labs all over the country I don't even know about. They're just small, local.
By the way, I know Dr. Rabar offers testing to practitioners.
The Pacific Sibo Testing Center or something like that, he calls it, right?
LA Gastro, LA Integrative Gastroenterology.
So I need to
He's in Century City. Yeah.
Let me write that down. I need to put his lab on here. If anyone knows of, a place that I always just try and put everything here. So I got to write that down so I don't forget.
And I guess the reason why some of these labs do 2 hours is because technically the idea is if there's gases produced after a certain period of time, and, a lot of people talk about after 2 hours or after 105 minutes that it's in the large intestine, so it's irrelevant.
Right. And, while that might make sense, what about hydrogen sulfide? So let me explain that. I mean, that makes sense for hydrogen, but I'm using the test to diagnose both hydrogen sulfide and methane. And actually, you need the 3 hours for methane as well. So for hydrogen sulfide, what happens is it takes 5 hydrogens to make 1 hydrogen sulfide. So the hydrogen gas is being converted. And because the machinery doesn't test for hydrogen sulfide, what that means is that we would typically see no gas being made. We wouldn't see hydrogen. It's thought we wouldn't see methane. So we would just see what's called a flat line, like no gas. The thing of it is, a flat line in the first 2 hours, that represents the small intestine, would be a negative test. Right? That's like, great, you don't have SIBO. You need the 3rd hour because there should always be a rise of hydrogen in the 3rd hour because we have a lot of bacteria in our large intestine and they make gas. That's normal. That's healthy. These bacteria make a small amount of gas on a daily basis that we excrete. We don't even feel it or know it's there. That is normal. By the way, there's been studies on that where they put people into these like bubble chambers and like seriously measure all the gas they make. So I laugh at the thought of these experiments, right? Oh my God. Well, anyway, so in that 3rd hour, we need to see that there's a rise of hydrogen. And that's how we can tell a difference between a negative test and a hydrogen sulfide. The negative test could be a flat line for the first 2 hours or first 90 minutes or whatever, and then it will rise. That's negative because no small intestine bacterial overgrowth, but bacteria in the large intestine. What hydrogen sulfide will look like is a flat line going through. I mean, I can show you an example. Would you like to see an example?
Sure.
Okay, let me bring one up of what that looks like. Just a sec.
Yeah, so somebody had asked what are the 3 types of SIBO. So basically we're talking about, just to reiterate, hydrogen, methane, and hydrogen sulfide.
That's right. That's right. Okay, just a sec. I'll have it. Here we go. Okay, let me share my screen. So here is an example. So when I analyze a breath test, I'll just tell you the way I like to do it. You all might like to do it differently. I come into the table here first, and I first take a look at the hydrogen. For me, and I can explain all this if you want, but I'll just quickly say, for me, what's a positive is 20 or above. I don't need a rise, although there's caveats to that. So 20 or above in hydrogen within the first 2 hours. So did the hydrogen get to 20 or above in the first 2 hours? No. So the hydrogen's not positive. Taking a look at methane, I use Dr. Pimentel's criteria of 3 or above. Between 3 and 9, I need to see that there's the symptom of constipation to call that positive.
But the North American consensus and most of the labs
about to say,
yeah, okay.
10. So then from 10 or above, that's positive no matter what. That for sure. But Dr. Pimentel, and we could talk all about that if you want. So I use that. Did it get to 3 or above? No. Did it get to 10 or above? No. That's negative. Okay. So then what I like to do is come over and look at the pattern. And so what we can see is this flat line pattern. So from after 2 hours, 120, these 3 tubes here, these 3 samples, it's flat. There's no rise. That's when you know it's hydrogen sulfide. If you're looking here on the table, you don't see numbers there. It's just 1, 1, 1. This is a flat line. So it doesn't have to be absolutely 0, right? Here we're at 2s and 1s. I think personally, I've seen cases of hydrogen that are positive going up to...
Well, can you explain why that shows that's positive for hydrogen sulfide?
Because it's negative for hydrogen and methane. And additionally, there's no rise of hydrogen in the 3rd hour. These 3, this is the 3rd hour here. It's just 1. So it's 2s and 1s the whole way, or over here, a flat line. Hydrogen here is in blue. It's a little obscured by the other ones, but it's just flat. So this is part here would be negative if this rose. But because this part is flat, what that tells us is that there should always be hydrogen there in that 3rd hour. And so that tells us...
Why is that?
Because we have bacteria always in our large intestine that are always making gas. That's what I explained about the machine where they tested people's gas, right? So this is abnormal. And the reason we don't see anything is because this machine is not testing for hydrogen sulfide. That's why the technology is not there. So we just see nothing. Now, once we'll be able to test for hydrogen sulfide, we will probably see something going on way up here, you know? By the way, always make sure you know that when you look at the this representation here, this is the parts per million of gas, and this changes. This changes test to test. So please keep that in mind, because you might see a pattern that looks like a peak here and then a peak there, but maybe the scale only goes to 9. So it's negative. So just be sure you look at that scale when you're evaluating this. So that's hydrogen sulfide. So this is one of the reasons that I like to have a 3-hour test until we get this hydrogen sulfide capability. So
basically the rule is essentially if there's a flat line after 2 hours, then that indicates hydrogen sulfide SIBO.
Yes. Now I'm going to tell you something a little bit gray area here. I have seen that there can be hydrogen of up to around 6-ish, so long within this and still be hydrogen sulfide, so long as that 6 is not just all here in the third hour. Like if it was zeros all the way here and then, 6, 6, 6, I don't think so, because there's a clear rise right there in the large intestine. But if you see like 1, 1, 2, 4, 6, 1, 1, 1, 1, 1, that can still be hydrogen sulfide. It's negative hydrogen. That's a gray area, and I might be confusing people, but there it is. And now I want to tell you one other thing there. There can also be a little bit of methane also at the same time, a little bit, like up to about 3 if the person doesn't have constipation, and it can be hydrogen sulfide. So it's like, I know now we're starting to get into the gray area, but that's how it is, right? Of course, there's always gray areas.
By the way, for everybody who's not aware, you mentioned constipation. Typically patients with methane SIBO have constipation, and patients who have hydrogen SIBO typically have diarrhea, though it's not 100% correlation, right?
That's right. Right. So hydrogen usually goes along with diarrhea, methane with constipation. A mixture of those two usually is a mixed bowel movement pattern of some kind. Hydrogen sulfide in the SIBO studies goes along with diarrhea. However, clinically, I myself have always seen it correlate with constipation. And actually, Dr. Jacoby has seen it mostly correlate with constipation. When I asked Dr. Pimentel to help explain this, he said, okay, now we're going to get into another gray area, but here it is. It's likely what might be going on there is that there is methane causing the constipation. Hydrogen sulfide and methane, actually, those bacteria with methane, it's actually an archaea, but I'm just going to call it bacteria. They compete with each other, and usually methane wins for dominance. However, there can be a level of methane that is below what we can detect on the breath test that can still be in excess, causing constipation. We would need parts per billion to be able to detect it. We have parts per million right now. And Dr. Pimentel did a study on this where he checked the amount of methanogens that were in stool. Methanogens can be overgrown in the small intestine or the large intestine, or both. And he found when they were 10 to the 4th to 10 to the 6th, at that level, that correlated with constipation, but did not show up on the breath test. So
now, do you know, because I was just looking at a GI map today for a patient who had some indication of Methanobrevibacter in the stool, but I think that 10 to the 4 to 10 to the 6 is below what they consider an abnormal level. I think
I've never made sense of it and looked at that, so I don't know.
Okay, I think it might be considered normal, but I think optimally there should be hardly any, so it shouldn't really show up at all. So,
well, according to Dr. Pimentel, and please clarify this with him, below 10 to the 4th is normal.
Right.
10 to the 4th to 10 to the 6th is not normal. That's that at that level, you'll see constipation. At least that's what he found in his study. And then above 10 to the 6th, you'll still have the constipation, but now you'll see it on the breath test.
Yeah, so, I don't know if all the stool tests include Methanobrevibacter, but I know that GI Map started doing it about 6 months ago or so. A
little longer than that.
Longer than a year ago, something like that.
Yeah, so the concept here would be that there's hydrogen sulfide, but there's also methanogen overgrowth that we can't detect on the breath test. So we're calling it undetectable methane that is causing people with hydrogen sulfide to have constipation. That's a theory. Now, also there are articles showing that hydrogen sulfide overgrown in the large intestine has correlated with constipation. So obviously there's more to figure out here. We need more studies and sorting out. But right now what we know is hydrogen sulfide overgrown with SIBO is diarrhea.
Somebody asked again, why does a flat line in the third hour show hydrogen sulfide SIBO?
Because we normally have a lot of bacteria in our large intestine, right? That's normal. We all know that. That's our microbiome. They normally make hydrogen gas. That's normal. They do that. We should see that. In the third hour of the test, after 120 minutes, we should see a rise of hydrogen indicating the normal bacteria in the large intestine. Now they are there. We can't, what's happening is the hydrogen is being converted into hydrogen sulfide gas by sulfate producers. And we're just not seeing it because the machine doesn't test for it. So it looks like there's no gas. There is gas, but we're just not seeing it. Now, I'm going to tell you one more gray area thing. If you want me to stop doing that, I will, but I'm just going to do it.
Great. We want the gray areas.
Okay, now I have to remember what it was. Hold on. Remind me what we were just saying. That
hydrogen sulfide in the third hour and
okay. Oh yeah. Okay, so while Dr. Pimentel and team have been studying with their new machine in research hydrogen sulfide, what they're finding when they're actually testing the gas is it's only a minority of hydrogen sulfide patients that actually have a flat line. So we can only detect a minority of hydrogen sulfide patients with this flatline presentation I've just been discussing. We're missing so many patients. So what that means is that people have positive hydrogen, they have positive methane, they also have positive hydrogen sulfide. Like there are going to be patients that have a mixture of all these gases, or maybe even hydrogen sulfide's dominant. We can't tell it all because they have hydrogen and methane there. And so we're going to need this machine when it comes out.
Right. And then, of course, the methanogens eat the hydrogen. So there's this competition that goes on.
That's that competition. Mm-hmm.
Yeah. So we just mentioned constipation, diarrhea, and, taking a careful history is so crucial. But there's a lot of times if you just ask a patient to fill out a questionnaire and they just check off constipation or diarrhea, there's a lot of confusion about that. And people have a lot of different concepts about what does constipation really mean? Is it just refer to somebody who hasn't gone to the bathroom in 3 days, or does it refer to somebody who is in the bathroom for a long period of time and just nothing comes out, or it's just maybe you can go into some of those subtleties, because I think that's really key to being able to get a careful history, is being able to probe the patient about exactly what they mean when they checked off, say, constipation or diarrhea.
Okay. Well, I just thought of something I want to tell everyone listening, that I actually did a free webinar where I brought people through how to interpret breath tests. You can access that. So, if you want to see me explaining with test examples how to interpret breath tests, I did it in January, and you can get it by, if you go to Sibo Info and click over to the Pro Course website and then sign up there to get free lessons, you'll get access to that webinar.
Cool.
Yeah, so it was just it was like a free, advertisement for the Pro Course, and I was teaching all these things, and I taught about 25 minutes on test interpretation. I just want to make sure you could access that, okay?
Great.
Okay, so back to your question on constipation, diarrhea, and history. So these are described and defined by frequency and texture, and also like feelings of how it comes out, like urgency or straining. And so we have to take all three of these into account. And sometimes patients describe, let's say, constipation because they have to strain when their stool is daily. And
by the way, everybody should know that Allison has a coffee mug with the Bristol stool chart on it.
I should have brought it in here. Very proud of that mug. I also have the Bristol stool chart on my pencil holder. Now, you guys, here's the reason I have it like here on my desk. I still don't have it memorized. Whatever. I'm only using the brain space for the most important things. I can look at this chart whenever I want. So Bristol stool chart, type 1 deals with this is mostly with the texture. 1 is the balls, and then next, number 2 is the balls stuck together. And then number 3 is even a little bit more loggish, but there's still some pellets or balls in there. 4 is the log. And then we start getting into diarrhea, blobs, mushy, and then watery. They make these in all kinds. There's like SpongeBob SquarePants Bristol stools. There's like Barney the purple dinosaur Bristol stools charts. So anyway, knock yourself out and find a fun one, right?
Dinosaurs get Sibo too.
So anyway, so let's talk about the texture there. So that's the texture, right? So, the idea is if it's all watery, that's diarrhea. If it's dry, like it's sat for a while and the water's been reabsorbed into the body out of the stool, then it's going to form these pellets or balls. So that's one way to define it. Another way is the frequency. Normal is 1 a day, or 1 or 2 or even 3 a day is considered in the normal range. So above 3 is considered too many. And I think we have leeway here. Some people might have a bowel movement after every meal, and even a fourth small one that's totally normal, that feels fine to them. But generally, it's 1 to 2 a day. So with constipated people, the typical thing is 1 every 3 days, chronic constipation, sometimes less. So we have to take into account frequency, texture, and then is there straining or is there urgency? Urgency is, of course, comes in different ways as well. Sometimes there's a feeling of urgency and then nothing comes out. The classic is there's a feeling of urgency with diarrhea, person has to run to the toilet, can hardly get there in time. And out comes, watery, loose stool, that's just a horrible thing, because any errand, any leaving of the house, they have to map where all the toilets are. So it's very, very difficult. Chronic constipated people tend to not actually feel that constipated feeling. That when a person, like a normal healthy person, if they get constipated for a day, they get an awful sort of toxic backed up feeling with just this constant sense of anticipation, like I just need to go, when's it going to happen? Chronic constipated people don't have that. They are like, well, whatever, And then diarrhea people are very bothered by their urgency. So the mixed presentation can be any kind of conglomeration of this. I know, Ben, you and I have talked about it before. Some of these kind of seem to fall more into like a fecal loading or constipated pattern, but we can define it however we want. But mixed generally is when there's some characteristics of constipation mixed with some characteristics of diarrhea. And like I said, some patients they might have normal form stool every day, but if they have to strain, they call that constipation. And in fact, it sort of is a form of constipation. So, a perfect normal healthy bowel movement should come, you get an urge, it's not crazy urgent, you go, it comes out easy, there's no stickiness, there's no fattiness, etc.
And is that urgency, does that tend to be more characteristic, do you find, of hydrogen or methane?
Absolutely, more so with hydrogen. And in an interview I heard with Dr. Pimentel recently, he was postulating that possibly the diarrhea that we've always associated with hydrogen actually might be due to hydrogen sulfide, that there's been this hydrogen sulfide there that we couldn't detect, and we will be able to detect. The theory right now for that diarrhea, the mechanism of action is that it's actually quite toxic and caustic to the lining. Kind of like, how food poisoning bacteria are, they're quite stripping and caustic, and that it's that sort of a mechanism. And the mechanism for constipation with methane has to do with it interacts with the nervous system in the lining of the small intestine and actually causes a slowing of motility. Sometimes it actually increases these like non-propulsive movements, so that there's just like this kind of hyperactivity that with nothing moving forward. And sometimes it even causes little reverse motility. And we do often see, not always, but often patients that are methane dominant have nausea, burping, and acid reflux, one or some, because those are all sort of upward, backward symptoms.
But it can still be the case, correct, that patients with diarrhea can still have problems with motility. Isn't that right?
In the small intestine, absolutely. So the typical scenario for a SIBO patient with diarrhea is that they have deficient migrating motor complex. They have slow motility in the small intestine.
Maybe for those of us who are not familiar with the migrating motor complex, can you explain what that is?
I did earlier, but I can do it again. That's that washing the dishes, sweeping motion. So just briefly again, it's the movement that occurs when we're fasting. So between meals and overnight, it's meant to clean debris, bacteria out of the small intestine, and it's like this quick sweeping motion. And like I said, it's like washing the dishes after you eat, and it is the number one protection against getting SIBO. And there's all kinds of diseases, drugs, and injuries that can make it fail. As I've learned more, it's sort of amazing how many things can affect it and slow it down. So go ahead, Ben.
And Dr. Pittman he has this concept that you get about a food poisoning, and then you get the toxin the endotoxin secreted by the bacteria that causes the food poisoning that then damages the migrating motor complex. And he even has a blood test for that. So this measures the anti-vinculin and anti-cytolethal distending toxins.
I'd actually love to talk to you about that, because when we talked about IBS, I didn't mention it, and there actually is a test for IBS now. So let's come back to it.
Okay.
But I wanted to just mention that but what was I just saying, though, when we went off on this?
About motility?
Oh, yeah. That the person with hydrogen dominance and diarrhea, they have slow small intestine motility. So lack of migrating motor complex in the small intestine, giving them the SIBO, right? Because when there's stagnation, the bacteria can overgrow. And then the hydrogen gas, who knows, maybe it's hydrogen sulfide, then is affecting, diarrhea. And we mostly have thought that it's affecting the large intestine and causing actually fast motility in the large intestine. So that would be the typical scenario for diarrhea SIBO: slow movement in the small intestine, fast movement in the large intestine.
And that explains why when we get to treatment in a little bit, even patients with diarrhea can benefit from agents that increase motility.
Absolutely. We're not increasing the motility of the large intestine. In that case, we're aiming at the small intestine. Absolutely. Yeah. And the different GI organs can have and do have different motilities, which is a really interesting concept. So I don't know how many of you have seen gastroparesis patients, that slow stomach emptying, slow stomach movement, very, very difficult group of patients. But I have seen many of these patients where they have that, and then they additionally have diarrhea. So they have nothing's moving in the stomach, but then they have diarrhea in the large intestine.
A couple of people asked about the vagal nerve, which is the nervous part that helps to control the signals to the muscles in the intestines.
Any specific question, or just generally talk about it?
Steve, what did you want to know about it? Let's see. Can you unmute yourself, Steve?
Many people want to do that, right?
Okay, there you go.
Just, dealing with the psychomotor portion of that, how have you've treated many patients with this, but if it's still a lot of problems up there, you get pretty stagnant in your care? Is that pretty correct?
Meaning are you concerned that stress might be inhibiting the vagus nerve? I haven't suspected that. I mean, I know stress can affect our GI, of course. It could be my group of patients, but what I've generally seen is the stress is coming from the SIBO and the symptoms. And when we bring the SIBO down, and the symptoms come down, their stress gets better and better, the anxiety gets better and gets alleviated. That's predominantly been what I've seen. I myself, just in general, as stress as a cause of SIBO, because I think a lot of us wonder about that. I've only heard of one case in my own self, somebody who came to me who it was pretty clear they had a very severe case of stressful events that brought their stomach acid down, inhibited their motility, inhibited their enzymes. These things were actually tested. They got SIBO, the stress went away, they started to recover, they did treat the SIBO, and that was it. They never got it back again. So
you raise the serotonins on that too, right?
Yeah. And the serotonins, of course, are so important in motility. So there's a lot of other things we could talk about with the vagal nerve, but just in general, the psychological aspects I myself have witnessed coming from the SIBO up really.
Right. And I remember taking a course from Dr. Karazian, who talked about the vagal nerve being a key factor, and that if you wanted to stimulate motility, you should stimulate the vagal nerve. And he recommended gargling and putting a
Tongue depressor, gagging, loud singing, humming.
Exactly.
So, I would not mind, if you want, I will share this with you. Let me bring up, I tried that in my patients and I did not find it to be effective. I was really disappointed. Oh, Steve, you didn't either?
I've never seen results of that personally either.
Okay, it's validating to hear that because I love Dr. Karazian. So I was like, and also I wanted to help my patients. Dr. Norala Jacoby, she's a colleague of mine in Australia, a SIBO expert there. She also did not find them to help SIBO patients. It's frustrating because Dr. Karazian has said it has helped his SIBO patients. But then, you just have to imagine we have different patient populations. But I heard a lecture by Neil Nathan, who wrote the book Toxic on Mold. I don't know if y'all know him. He's wonderful. I saw him give a lecture last year. I don't know how many of you might have been there at the Forum for Integrative Medicine. Great conference. And he lectured on polyvagal syndrome. And he shared all sorts of methods to help the vagal nerve. And he also mentioned that he didn't find the Karazian exercises, he said, to be specific enough. And I took that to mean maybe they're not honing in on the condition that it was needed for. Let me just take a minute, and I want to bring up for you what I collated together from his lecture, because it was very helpful. So just give me a sec here. And I have, these are all, I put this in my pro course, but I really want to share it with you. Second here. Here we go. Okay. Almost have it. Here it is. Okay. I'm going to share it. Oh, sorry, I just want to put this on bigger so you can see it. Okay, so this is a conglomeration of what I learned from him. So, and also I'll tell you that my research on the vagus nerve and the MMC has been very confusing, and I have not studied functional neurology. I haven't taken that series of courses. Some of you might be able to explain it better to me. But what I have found is that the vagus nerve stimulates there's the migrating motor complex. There's one that starts in the stomach, goes through the small intestine. There's another that starts in the small intestine itself. So the vagus starts the one that is in the stomach, but not the one that's in the small intestine itself. So there's some very confusing information. I've read some articles by researchers stating that the MMC is absolutely not turned on or stimulated by the vagus, and it's confusing to me. This is the best thing I can come up with. And I do want to just share one other little nugget, is that I have noticed there's quite a fad and a trend of people who are talking about SIBO saying, it's all about the vagus. Some of these people I really like and respect. But putting them aside, what I'm noticing is that people who aren't SIBO specialists are saying it's all about the vagus. And people who are SIBO specialists are not saying that. So now maybe we'll learn something more, but that's just something to note, okay? So anyway, here are these wonderful options we have. Neural therapy is where there's injections with procaine. That's been shown to help the vagus. Frequency-specific microcurrent has definitely been shown to help the vagus. And here I've got the, you won't be able to link to it, but if you just search these, you'll find it. We've got all of our nutritional nerve healers. We've got Karazian's exercises. There's PEMF, any kind of relaxational effort, intermittent fasting. Now we do meal spacing in SIBO. So where we don't snack between meals, if possible, if the patient can do it, because that allows for the migrating motor complex to happen because we're not eating, right? Now, these are specific polyvagal treatments. Polyvagal syndrome, so fascinating hearing Dr. Nathan talk about it. Basically, it's like when we don't feel safe, all sorts of things occur in our body that are not good. So he's got the Rosenberg exercises, cranial osteopathy or cranial sacral. Brain tap. I know a lot of people who are using that. The biggest one is DNRS. So I know so many of you know about that. I'm hearing so many good things about it, specifically for people who have so many food sensitivities and high sensitivity. So I think brain tap is sort of like a easier, gentler form of DNRS for people who just can't handle the full meal deal, right? Of course, there's EFT tapping, Peter Levine's VU, the listening protocol, and the electronic ear. There's more. Dr. Nathan's book lists a lot. So I just wanted to share that with you. Here are some other options.
Somebody mentioned coffee enemas.
Oh, yeah. That probably should be on there. I mean, I think that I could have put a lot of other things on there, right? That's just, I'm sure all of you have many things to add. So that's what I have to say about the vagus. Okay.
So let's go into treatment. When we have a patient with methane or hydrogen, or let's go into what we should first start thinking about in terms of treatment. Should we think about diet first? Should we think about antimicrobials? What should we think about first?
Okay, well, diet can be used anywhere along the process, and I think it's sort of case by case. Let me just talk about that first. The benefits of diet are that it's an excellent symptomatic controller. And, a patient, it's something they can do at home, obviously. And we typically see in the 70% to, 60 to 90% range of symptomatic reduction. Some people get 100% symptomatic reduction from diet. The bad side is they're on a restrictive diet. They're all lowering carbohydrates, which, in general could be positive. But what winds up happening is, due to the symptoms and the extreme sensitivities people have and the anxiety, patients tend to restrict more than even is needed. Or just they do need to restrict that much to get the full symptomatic relief. And so what we find is people can get stuck in this. And what we want to do then is use antimicrobials to actually, because the diet does not reduce the SIBO itself. I mean, I think it could probably bring it down a little, but it doesn't eradicate the SIBO. It doesn't remove it. We need antimicrobials for that, antibacterials. And so we use them often so that people don't have to be so restricted in their diet, right? There are other benefits with diet. I mean, of course, generally low carb diets, can help health in many ways, so long as it's not too restricted. And also, I think, it can bring bacteria down a little bit, so it might help with die-off. I think it's generally supportive to treatment, and there's other things, but the main thrust with diet is symptomatic control. And where this really comes into play is for our chronic patients who, they have underlying conditions that cannot be cured, like Ehlers-Danlos or something like that, and we're doing management. And then diet is a wonderful management tool. So
does everybody with SIBO, do you recommend the same diet? Do you recommend a different diet for methane versus hydrogen sulfide? Does it depend on the person? Do you ever, try to figure out exactly which foods they might be sensitive to by doing food sensitivity testing or elimination to start with?
Oh my God, you've thrown out 50 questions and I want to answer them all. You're just going to keep going and it's going to keep be more interesting.
Sorry.
Okay, so there's no specific diet difference between hydrogen and methane, except there is some research to indicate that fat might not be as good for methane. I have to say clinically, I haven't seen that pan out. It's in research. I haven't seen that pan. So the general SIBO diets, which are, I can explain in a minute, they're all low carb. They work for hydrogen or methane. It's pretty rare to see a low carb diet reverse someone's constipation, but it will help other symptoms. It certainly can help diarrhea. Hydrogen sulfide, we can consider a low sulfur diet. However, clinically, I have seen mixed results. I have seen some people who absolutely need to be on a low sulfur diet, and that's so important for them, and other people who it makes no difference for. It probably has to do with the degree of severity. Also, when I look at the studies on diet for for hydrogen sulfide, they're very mixed. Like there'll be a study that says, oh, meat is bad. And then there's another study saying, no, you were misinterpreting that. In fact, you were measuring binders and there's no hydrogen sulfide production increase. I've seen that with a lot of the even brassicas. Brassicas have sulfur, but then there's another study saying, no, in fact, it doesn't increase production of hydrogen sulfide. So what that means to me is that we can try a low sulfur diet in our hydrogen sulfide patients as an experiment, as a trial, see if it helps them. But if it doesn't, don't add that extra layer of restriction. Like go by whether it actually really helps them or not. I just mean don't go by rote. Like you have hydrogen sulfide, so you have to be on a low sulfur diet. Just see if it works for them clinically. Now, I would like to answer the question about the blood testing, food allergy blood testing. That is a different kind of sensitivity than what we have in Sibo. In Sibo, we have a fermentation reaction. It's actually about the amount of carbohydrate substrate that we're feeding to the bacteria that are overgrown. They take that and turn it into gas. The volume that is given to them correlates to the volume of gas coming out. Although it's not like that for every carbohydrate. For each person, there are going to be carbohydrates that their bacteria like to eat and ferment, and others that they don't. That's just how it is. Like I've looked in microbiology books, and you can see lists of bacteria and what carbohydrates they eat, and then they don't eat others. So I think of that how people like certain foods and don't like certain foods. So that's a fermentation reaction. It's not like a protein allergy, like a food reaction. Now, our patients certainly can have those reactions at the same time, right? They can have protein food sensitivities.
Can have multiple layers.
Right. So you could consider doing that just to lower the noise. But I have a concern in that because at least 50% of patients with SIBO have leaky gut. SIBO causes leaky gut in about 50% of patients, according to the studies. I find that statistic interesting because I think we would assume it's more than 50%. And actually, when I was running these tests on people, I also found that. I found patients that didn't have it and patients that did. And I was mostly running Cyrexes. I don't know if that was the best one to run, but that's what I was running. So if they have leaky gut, they're going to just show up, right, with a ton of food allergy blood sensitivities, right? So I'm concerned about adding more and more dietary restrictions. We can use that to see and help people identify maybe some of those foods really are causing them awful symptoms. Yeah, get it out. We want them to feel better. But I would focus more so on trying to eliminate the SIBO so that then the leaky gut could be healed. And then they wouldn't have as many reactions. It's always a tricky thing. So in terms of all these different diets, I use different diets with different patients. That's because I'm very, very familiar with all of them. And so I'll just name some of the ones we use. There is my SIBO-specific food guide. Dr. Jacoby made a variation of my SIBO-specific food guide called the C Bo Biphasic Diet. She just took my guide and put it into three phases. I know it's called the biphasic, but there's actually like 3 phases. What my diet is a sort of a conglomeration of the specific carbohydrate diet, so that's SCD, and the FODMAP diet. So there's those. And then there's Dr. Pimentel has one that's called the Cedar-Sinai low fermentation diet. And by the way, you can access all of this on my website under treatment diet. I have all of these listed and links to all the resources and all that. And then Dr. Norm Robillard actually has his Fast Track IBS diet, which is used for SIBO also. There's the GAPS diet, which is a variation of SCD. I used that early on, and I found I went away from using it. I love GAPS diet. There's many wonderful benefits, but I just found it wasn't really necessary, and I was more so using these other ones. And of course, there's paleo. A lot of people use autoimmune paleo. It's not really designed for SIBO, but you can adapt anything. And really, that's the most important thing I feel is to just pick a lower carb diet, and you can start your patient with that. And then what you do is you have them customize it to themselves over time by doing trial and error. Now, sometimes patients are afraid to do that. a lot of times, because they've had so much trauma with food causing symptoms that they're afraid to try things. Once you've eliminated them and they're feeling better, they're afraid to try, right? But what we always find is that there are foods that a patient can now try, foods that are higher fermentable in whatever diet you're looking at, high FODMAP or whatever, high fermentable, whatever the grading is, illegal on SCD, that they can totally tolerate, because everybody's individual. So anyway, whatever you can do to help them try it. But that's what you do. It doesn't really matter which one you use, I think, because so long as you explain that you're not going to be following these diets like a Bible and you're going to be experimenting no matter what the diet says, because like SCD says you have to fanatically adhere and these foods are illegal, tell them to ignore that. So long as you explain that, and that then you start them with any diet, and then you're going to customize it, and the name of the diet becomes irrelevant soon enough.
Now, many of us have treated patients who've been on a very restrictive diet for very long periods of time, and so there's always the worry that they're going to end up being more unhealthy because they're eliminating all these healthy foods, and sometimes they end up with fewer and fewer foods that they can tolerate. And so, if, for example, the low FODMAP diet eliminates cruciferous vegetables and avocado, and there's so many foods that you're not supposed to eat on a low FODMAP diet that you're really decreasing your potential long-term health. So what do you think is the longest period of time somebody should be on a restricted diet like a low FODMAP diet?
Before I answer that question, don't forget it. I want to speak to some of the stuff you said because I actually don't agree that that the diets as they're written on the page are unhealthy. So for instance, even in low FODMAP, the part of the diet where you're supposed to do 4 to 6 weeks of actually low FODMAP, actually almost all of the cruciferous are allowed in small amounts, and avocado is allowed. You're allowed 1/4 of an avocado. You're allowed
on which version?
On low FODMAP from Monash University. By the way, you guys, if you don't know, the app for low FODMAP diet is the official one is from Monash University. So it looks like this, because there are imposter apps out there. And I know this because of patients who they come back. I'm like, oh, get the app. They come back, they've downloaded some other app, and then they're like, well, I can't have this. I'm like, that's not the truth. And I look it up and I'm like, is this the app you're using? And they're like, no. You always have to say Monash, okay? So for instance, if we go to Food Guide and we just look up broccoli, let's just do it for the heck of it. Of course, now my phone's acting slow. Right.
I guess the versions I've seen of the low FODMAP.
Here you go.
Diet.
3/4 of a cup is A-OK.
Oh, okay. Is that a change that occurred at some point, or what did it used to? No. Okay.
It's always been okay to have a small amount. So this is the big thing with FODMAP diet that's different than the others that I actually like, is that they've measured the amount of various fermentable, not all, but some of the fermentable aspects in carbohydrate foods, and put it through their clinical filter, deciding how much you can have. And what I love is they give portions. So whereas SCD is all or nothing, illegal or legal, FODMAP says, no, you can have 3/4 of a cup. Now, honestly, this drives patients crazy. It drives most people crazy because most people are not into portion sizing, right? But why I like it is because you don't say you can't have broccoli. You can have some broccoli. So just whatever, so avocado, you're allowed all these things. This is why I dispute that the way the diet is written is actually not healthy. The problem is that patients don't. Patients are like, well, they'll see, well, I can only have whatever, 1/4 cup of such and such. That's too confusing. Forget it. And then they restrict the diet more. Now, I don't personally, in my nutritional assessment, I don't believe any of the diets as they're written are unhealthy. So that's an important point. And actually, the FODMAP diet greatly encourages polysaccharide fiber, which is one of the biggest problems for SIBO, and why this diet often doesn't work for alleviating symptoms in SIBO because they allow lots and lots of high fiber food.
The low FODMAP diet, you're saying it often doesn't work because it has too much fiber in it.
That is correct.
And the fiber's coming from which foods?
Oh, all different kinds of foods. They allow grains. SCD is grain free. So this allows grains in certain portion sizes. Grains are one of the greatest source of fiber, and also beans. They allow various beans in 1/8 or 1/4 cup amounts.
On the low FODMAP diet allows beans?
Correct.
Boy, I guess I've been looking at the wrong version of the low FODMAP diet.
Just go right to Monash here. So for instance, you're allowed lentils. And I shouldn't say allowed. I shouldn't be saying that. So 1/2 cup of brown lentils are completely fine on low FODMAP.
Wow. I think that there's versions of this that have been printed out and circulated.
Okay. This is why you want the app. The app is updated with all their research. You have to pay like $7. It goes to their research. I'm not sponsored by them. I receive no money from them. I just have the app because it's actually very frustrating because they've stopped publishing their research in papers. They used to. They had all these papers on the FODMAP levels, in fruits, vegetables. They don't do that anymore. The only way they publish their research is with this protected app that we are not allowed to use any of that information because they have rights over it, which is not okay with me in terms of our scientific community. But whatever, there it is. It's in the app. So do use the official sources of these diets. Now, let me get back to the actual question you asked, which was...
I don't remember what it was.
Now we have to remember it. Darn it. It was a good one. How long?
Yeah.
Okay. So, you can start diet right away to bring symptoms down. You can start diet during the antibacterial treatment. You could wait, start it after, see what the antibacterials do. Now, one of the main reasons you might not want to wait is if you are doing herbal antibiotics, and we're going to have to get into all these soon enough. Herbal antibiotics take longer. They take twice as long as antibiotics to achieve the same result. They are equally as effective. They just take longer. So a standard course of pharmaceutical antibiotics in SIBO is 2 weeks. Sometimes we go for 3 weeks if a person has high gas. High gas for me means getting around the 70 part per million range. For herbal antibiotics, one course is 4 weeks. Sometimes we go for 6 weeks if they have high gas. I know a lot of people just practitioners put people on herbal antibiotics for 2 months or 3 months. I don't do it because, at least in my patient base, I have found over and over, I tried it, I found over and over that my patients at least begin relapsing somewhere between 6 to 8 weeks. Now, of course, I have exceptions. I have exceptions to that rule. There are always exceptions. And I found the same thing with antibiotics past 3 weeks. Because, why wouldn't you just put someone on rifaximin for, until it's gone? I find there's a point of diminishing returns and it peters out. And so in my experience, I have people actually getting their symptoms back while taking the herbal antibiotics. It's time to stop, right? So anyway, and the other important point here is multiple rounds of pharmaceutical or herbal antibiotics are typically needed in treating SIBO because this isn't an acute infection. It's not technically an infection. It's an overgrowth or a colonization. And so for a colonization, we just have to get that load down to the appropriate level, and that just takes time. So my whole point in telling you this is that if you're using herbal antibiotics course after course, you might be looking at, a couple months, 3 months. You may want to begin getting symptoms down before waiting that long. So you may want to bring diet in to help with that. So, now comes the question of how long. I think it's okay to do it all during the treatment. After treatment, at that point, I think it's great to begin expanding. Honestly, you can really start expanding, so to speak, very soon. You just need a period of time, maybe even just 2 weeks. You get to decide 2 weeks, 4 weeks to get the symptoms calmed. Usually you see it within 1 week, okay? And then you can now start challenging to just find out which foods really are bothering them or not. Challenging foods in is a very lengthy process because we all know this, right? You challenge a food in, let's say it did cause a symptom. Now you have to usually wait about 3 days for everything to calm down before you can try something else. What if that bothers them? Oh my God, then it's another 3 days. It just takes a long time. So factor all this in. But let's say you've done the antibacterial treatment. They're doing well. Now you really want to start expanding. They have some confidence. I would start doing that right away. You're definitely going to encounter patients that won't do it. And I'm not sure what to tell you. I've tried all kinds of methods. I bet some of you have too. I usually just resort to begging in the end to get them to just expand their diet. You have these exceedingly, it's like a conditioned response, right? They had so much pain and suffering. Even though we've got the test down, everything. This is a minority, but I'm speaking to it, right? So anyway, begin expanding. Now, what if you have the chronic scenario, somebody with an incurable underlying cause, like systemic sclerosis? They're always going to have SIBO. They're going to be on diet forever. So that's okay. You just expand it to their tolerance. I've had systemic sclerosis patients that could eat more than a fourth a cup of beans. Seriously, they were able to expand because we've gotten their test negative and we're controlling it. But they're not on a complete normal diet. They're following their own version, expanded. So I don't have a set time, do I? If I was going to say something in general, I would say the post timing, no longer than 3 months. And really, I think you should be expanding within that if you can get them to. The reason I say 3 months is because average relapse time after getting a test negative is 2.5 months for chronic patients. That stretches out as we keep treating and managing better. But so 3 months gives you that little extra insurance of let me just see what's going on during this first bout.
So let's go into treatment with antimicrobials.
Okay,
Can I
so
ask
for
a really
pharmaceutical
quick question?
Sure.
First. So sorry, how do you feel like with antibiotics and low FODMAP? I've heard from multiple doctors, like you have to do high FODMAP foods during antibiotics in order to coax it out. How do you feel about that?
So this is what Dr. Pimentel likes as his strategy. And he's not wrong in why he's saying this. When you look at articles about persisters, bacteria that are persisters, they go into sort of a dormancy stage. And if you're feeding them their food, carbohydrates, they replicate. And that's when pharmaceutical antibiotics will work on them when they're replicating. So there's a good reason why he's saying that. However, before I ever heard him say that, myself and my colleagues who were all focused on SIBO, we didn't do that. We did low carbohydrate diet to control symptoms while treating, and we had excellent success for 3 years. And all I did was see SIBO patients. So what that means to me is that it doesn't matter because both ways are working. So if both ways are working, you don't need to do it either way. You can choose whatever way you want to do it. So what I do with that is if somebody comes in and they have not been put on a SIBO diet yet, they're not on one yet, and I'm doing pharmaceutical antibiotics or elemental diet. Elemental diet, we'll talk about that in a minute. That's also a 2-week course. Those are quick. So I won't put them on a diet because we're going to immediately treat and we're going to start getting those symptoms down. After the course is over, we'll evaluate where the symptoms are. And at that point, I'll put them on some kind of a prevention, lower carb diet. Maybe not something super strict. Like Dr. Pimentel's low fermentation diet is not super, super strict. So maybe I might use that one or an expanded version of one of the others. Maybe you could put someone on FODMAP at moderate, not low FODMAP, but moderate FODMAP, something like that. So, but if a person's coming and they have really bad symptoms and we're going to use herbal antibiotics, which I know take longer, I'm probably going to put them on a lower carb diet to get the symptoms controlled. I've done that to more patients than I can count and had successful outcomes. So
it may be that herbal antimicrobials don't work the same way that antibiotics do.
Maybe so. Yeah, maybe so. However, I've had more patients than I can count on pharmaceutical antibiotics with extremely strict low carb diets and had complete success. So even though the theory is there with full, citations, I don't see that bear out clinically. So I think it's not key. What I would say is it's not make or break. It's not key. Like, it isn't true that you have to do that for success, because myself and like Dr. Sandberg Lewis, all of us, we just did it for years and years and years. I still do it, and there's no problem. So that's what I would say. And also, one other caveat here is I actually saw a lot of patients come in when this first made the rounds. This first made the rounds like in 2015 or something, when Pimentel announced it at the Sibo Symposium. A lot of patients came in where their doctor had done that. They had thought they needed to. But these were the kinds of patients that are the 5 food patients. They're down to 5 foods. We all have them. They're that sensitive. They can only tolerate 5 foods. But they were told to eat all these foods they can't tolerate so that the treatment would work better. And what I found with these patients, obviously they were coming to me for failure, is that the actual treatment did not work when they did that. So my personal experience and recommendation is, if you have someone who's on a very restricted diet, definitely don't increase their carbs during treatment. That doesn't go well. Okay, so now we want to move on to the antimicrobials.
Yes.
Okay, so for pharmaceutical antibiotics, we have 3 main ones that we use. Rifaximin is the name of the drug. It's sold as Xifaxan in the US at least. We use this for all kinds of SIBO. And this is used at 1650 milligrams a day, broken up usually in 3 doses. Comes as 550. Before I say any of the other ones, it's very, very expensive. Not everybody's insurance covers it. We've been struggling with this for 10 years. It's approved for IBS diarrhea type, but even still, many insurances don't cover it. So what people do is they often buy it from Canadian or overseas pharmacies. Patients will get it there. Now, this has been a bit controversial because when I first tried this, myself and my colleagues had bad results. I think, whatever brand we were getting was cut with something, and it was giving people terrible, terrible symptoms. It was clear it wasn't acceptable. But since then, there are a lot of compounding pharmacies that I think are maybe making it cleaner or something. And I've heard a lot of people report fine results, like Mark's Marine. One of my local pharmacies here is doing it now. For a long time, what I did was there was a Canadian online pharmacy that was importing branded Xifaxan from Italy, so it wasn't like generic. One of the issues is that the generic is not exactly the same as the brand. The difference is the brand Xifaxan is not absorbable into the body. It stays in the small intestine and does its work there. The generic does absorb into the body. However, I'm not really that concerned because rifaximin is so incredibly safe and actually beneficial. I also don't really think that if it absorbs into the body, it's going to be that much less effective. My concern is really just much more about adulteration. I've had many colleagues tell me that the generic or compounded rifaximin works, and I've had many colleagues tell me it doesn't work. I wonder if that's just because everything we ever use for SIBO works for some people, but not for others. So this is just all I know on it. I'm sure lots of you have used generic and have probably had your own experiences that you could say. But I just wanted to make comment on the expense issue here. Now, the other antibiotics we use are either neomycin or metronidazole. Metronidazole is also called Flagyl. We use neomycin or metronidazole when we are treating methane. So we need double antibiotic therapy for methane because methanogens are archaea, not bacteria, and they respond to different medicines. So what we do is we would do for someone with methane, we would do rifaximin plus neomycin. Neomycin is used at 500 milligrams twice a day, and these are 2-week courses. Or we would use rifaximin plus metronidazole. Metronidazole is 250 milligrams 3 times a day, also for 2 weeks. These are taken at the same time. If somebody just has hydrogen, we use rifaximin only. Now, hydrogen sulfide, let me answer that at the end because it has its own thing. So that's pharmaceutical for the main 2 gases. Now let's do herbal. Herbal antibiotics, there's two strategies. There's the strategy I use is single herbs, used usually two single herbs together. But what a lot of docs do is they use combination formulas. Everybody has their favorite, and those work too. I think some practitioners get confused because now SIBO is such a big deal and fad and everything that so many companies market their combination antimicrobial like this is the treatment for SIBO, and I think it's confusing to people. So let me just give you the background behind it. The main herbs that we tend to use singly are berberine containing herbs like golden seal or Oregon grape or coptis, neem, Neem, oregano, and we use Allison. And the company I usually use is AliMed, or through Emerson it's sold as AliMax Pro, same thing. And I have also heard that there's success with NFH, Allison Sap. The problem is it's half the potency of AliMed or AliMax Pro. So normally we use 6 pills of AliMed or AliMax Pro. So for the NFH, we have to use 12 pills, and it's a bit of a pill burden. Let me just quickly give you the doses for berberine. I typically use 5 grams. That's like heroic doses. That's what my colleagues and I use. By the way, the reason we use that is because we consulted with Stefan Brunner, who wrote Herbal Antibiotics, the book Herbal Antibiotics, and that's what he told us to do. So that's what we did, and it worked. Now, since then, some of my colleagues have experimented with like 6 grams and found it to work. So I would say in the 6 to 9 gram. I'm sorry, I'm saying that wrong. 3 grams. 3 grams, 5 grams and 3 grams. 5 grams winds up usually being around 9 to 11 pills. So that's a pill burden. And 3 grams is more tolerable. So anyway, let me just describe these for a moment. What we do for hydrogen is we use 2 of them. The AliMed is what we need for methane. So if somebody has hydrogen, we would use either berberine plus neem, berberine plus oregano, or oregano and neem. Those 3. We just use 2 of them. Why don't we use more? We've never seen it be needed. We don't see any more lowering of gas when we use more herbal antibiotics. 2 gets you to your maximal thing. So now let me digress. This is why I don't tend to use combinations, is because we know we need multiple rounds of treatment in most people. I'd say on average 2 to 4 rounds are needed. And I see people becoming clinically resistant very often. Like I said, they begin relapsing while they're taking the herbs. So I need to switch. Now, if I've used a combination formula that has 15 herbal antibiotics, what am I now going to use? So that's why I don't do it. Now, what I've heard from my colleagues who treat SIBO that see much more of the 1/3, like the patients, like where they give 1 round of treatment and then the person's all better. I don't get to see those patients really very much. So I think if you're seeing the 1/3, now how do you know ahead? I don't know, but if you're seeing the 1/3, I think the combination is of course fine because you're not going to need to do multiple rounds as much. But I just don't have that luxury. So I just wanted to explain my reasoning of why I do it that way. So now, if the person has methane, we would choose one of those 3 herbs that seems to work on hydrogen, berberine, oregano, or neem. Choose one of those and add the Allison to it. And so then you're doing 2 there. And the dosages for neem, I've been using the brand Ayush. By the way, I don't have any association with any of these companies. I've been using the brand Ayush at 6 a day in 3 doses. And for oregano, I've been using ADP. I find I use about 6 a day of that. I find that's a tablet. I find that the oregano that's liquid, that's oil, I need to use higher dose and it's more caustic. Many people get irritated from the causticness of oregano, and I find less of that with the tablet form, the dry form. So that's why I use that one. I'm not opposed to the liquid. If somebody wants to use that, that's fine. I tend to prescribe the ADP. So 6 of those. So there's one other thing we can use for methane, which is atrantil. Atrantil is a combination of peppermint leaf conker tree, which I believe is horse chestnut, and red quebracho bark. And what this does is it works a little different. This actually inhibits an enzyme in the methanogen so that it can't make methane. And it's the actual methane gas that's causing the constipation. So if you can inhibit that gas, you didn't have to kill the bacteria or the archaea, and you still get your result. So that's another option. I've experimented a lot with it. With all of these, I'm only telling you the things that I know to work. I do before and after testing on all of my patients. The reason I do that is because I'm a specialist, so I can, and I kind of have to because I got to really figure out what's going on. So I've seen this with proof, all of these work. And I also did that with a Atrantil, and I saw that it lowered methane. It doesn't work in everybody, neither does anything I just mentioned. Sometimes you try one of these things and it just doesn't work in a given patient. And I mean, like you've retested, and it's because symptoms can take a while to come down, but when you're retesting, you can see those gas levels coming down, sometimes before symptoms. So Atrantil, also 6 a day. I have seen miracles with this. I also see miracles with rifaximin a lot, but with Atrantil, the miracles will happen. The only way I've ever seen it is quick, like within 4 or 5 days. So a life of constipation, obviously this is for methane, eliminated in 4 days. It can be amazing. And then in other people, it does nothing, right? So, but you would just do it the same a month, just like you would when you're treating the others. And I think it's great to combine it with the others as well. So, you do Atrantil plus, say, berberine. So that's it for the herbs. Now, I didn't do the hydrogen sulfide. So let me just finish that bit. So hydrogen sulfide, we don't really know what the proper answer is. What Dr. Pimentel has recommended for all these years is to just treat the presentation. All the treatments I just described to you, you can do. Just do they have constipation or diarrhea, and you treat it like that. I did that early on, and I did not find that to be successful. I do want to note that my wonderful colleague, Dr. Leonard Weinstock, who many of you may be familiar with, does a lot of SIBO studies. He said he definitely found that to be successful. So it just, I want you to know some people find that works. I just didn't find it worked. So that's still an option, right? Any of these treatments I just described for hydrogen sulfide. One caveat here is that Allison has sulfur, right? That's a sulfur donor. And I have seen that aggravate some hydrogen sulfide patients. However, I've also seen it work on hydrogen sulfide patients. I don't know why. So go figure. Okay, so that's one option. Option 2 is for hydrogen sulfide is bismuth. So there are studies that show bismuth binds hydrogen sulfide. The study that was done showed there was, after 7 days of basically 2,000-ish milligrams of bismuth a day, brought hydrogen sulfide down by 95%. I've tried bismuth with a lot of my patients, and what I found is 7 days is absolutely not long enough. It just comes immediately back. So I think we need to do it, 2 weeks or probably really a month. And I've looked into the bismuth safety studies, and it is used in many conditions for months and months. I feel okay about it.
Because bismuth is a heavy metal.
Right. I mean, it's like we have a concern, right?
Right.
And also I've had reports of people who have used, for all of you, you may know Paul Anderson has he has a compounded antibiofilm formula with bismuth, and now he sells it. What is it? Is it Designs for Health or
No.
Priority One? Priority One.
Yep.
Advanced Biofilm Phase 2. It's a bismuth product. I've heard reports of people who've taken that a long time, whether it's for antibiofilm or whatever, who are now showing, bismuth in various tests. So, we have a concern here, but I do feel a month is acceptable, depending on your patient and their situation. So I've definitely seen that work well. So that's an option. So with the sources, the way I've done it is I've gone to compounding pharmacies for it, and that's worked. It's either bismuth subcitrate or bismuth subnitrate. Usually they do subcitrate, but either can be done. And that's the way I've used it. I haven't used Paul's, because I haven't used his advanced biofilm phase 2 yet. It wasn't out actually when I went on hiatus yet, so I haven't tried that. So
I've heard of practitioners even mentioning some form of Pepto-Bismol, right?
I use that a lot. I've used Pepto-Bismol for my problem is it's got the salicylic acid, which is rough, on the gastric mucosa. I don't like that. We can do something to help protect them. But I have, I'm sure you all do too, patients from international where that is our only option. They can go and get Pepto-Bismol. So one thing I'd like you to know is that Pepto-Bismol, whether it's chewable or liquid, always comes with sugar alcohols that are fermentable and can aggravate symptoms. So the one that I've been using is by Target, when it's possible, is by Target. They have their own Up and Up brand, and it's called 5 Symptom Digestive Relief, and it's a swallowable capsule that does not have any sugar alcohols. So I don't know why Pepto-Bismol doesn't make a swallowable capsule. That's the only one I found. Basically, that's a capsule of Pepto-Bismol. So that has absolutely worked. Now, there's a third option, and that's high-dose oregano. So I use the ADP, and apparently this is an old chiropractic blastocystis hominis treatment that was told to me, and it seems to work sometimes. I've definitely had success with this for hydrogen sulfide, but it doesn't work all the time. And so what it is you do a loading dose for a week of 5 tablets of ADP, Biotics ADP oregano, 5 tablets 3 times a day for a week. Then you come down to 3 tablets 3 times a day for 3 weeks to make a month. So it's nice. Sometimes I have patients with blastocystis, so we can get that at the same time, maybe. So that's another option. There are some probiotics. There's some supportive things. So butyrate, hydrogen sulfide abolishes butyrate. That's supportive. Molybdenum helps with sulfur metabolism. There are things to consider that you don't want. Sulfur donors, like alpha lipoic acid, which is in Paul's advanced biofilm phase 2. Maybe we shouldn't, I don't know, that's got sulfur. My friend Greg Nye wrote a wonderful article suggesting, and this has been written by others, that maybe we even need sulfur in these hydrogen sulfide patients. You can go and read that article. If you want to find it, you can go onto my website under studies, go to 2019 and go under hydrogen sulfide. You'll see it there. So he thinks, so for instance, like Epsom salt baths with magnesium sulfate can often bother hydrogen sulfide patients. That's actually one of the things that I would say if I was trying to figure out if somebody was hydrogen salt, take an Epsom salt bath and tell me. And it's amazing how many people are like, oh my God, I felt so sick. Well, Dr. Nye suggests treating hydrogen sulfide with an Epsom salt bath. So you could read the article for yourself. But there are a bunch of supplements, that we could MSM, sulfur amino acids. Let me see, I think I have a list up here. Let me bring it up. So that you can think about, should we not be having these things? Should we? Brewer's yeast, berberine sulfate. Sometimes, they make it berberine sulfate. Glucosamine sulfate. And then bile. Some hydrogen sulfide bacteria feed on bile. So if we're using oxbile supplements in our patients, maybe not for a hydrogen sulfide patient. This is pretty uncharted territory, so there's no right or wrong here. So that's it for that. Now, the last thing we didn't mention was elemental diet. So elemental diet is a medical food of pre-digested nutrients, usually in powder form. It's supposed to have protein and amino acids as amino acids, carbohydrates as monosaccharides. Sometimes you'll see that there's oligosaccharides as maltodextrin, but basically shorter. And then it's supposed to be, fats as fatty acids, but usually it's not. It's just usually oil. So that's what a true elemental diet is. And there are many on the market. The one that was studied by Dr. Pimentel is Vivinex Plus. It's not flavored. Unflavored elemental diet tastes very bad because amino acids taste bitter and very unpleasant. So people can add flavoring. The way they used to do it for Vivinex Plus was they would buy Crystal Light and add that in, which of course is unhealthy, but then again, the person's doing it for 2 weeks, and if they can't choke it down. Well, then I found out that there's Neocate Junior. I've used Neocate Junior a lot. That's flavored. And then many years ago, myself and Dr. Sandberg Lewis went to Integrative Therapeutics and begged them to make a cleaner, greener product, and they did. It took them years and years. And of course, now for many years, Physicians Elemental Diet has been out by Integrative Therapeutics. And for those of you who read my newsletter, you'll know that we now have 2 companies that just created some new ones. Vita Aid has 2 new elemental diets, and Dr. Ruscio's functional medicine formulas has a new elemental diet. He previously had some semi-elemental diets, but he finally now has an elemental diet. Semi-elemental diets usually have the protein in not fully amino acid form. And also the product that he had, you had to add oil to, which is fine, but it's not like a complete thing. And then, I forgot to mention, of course, there's my homemade recipe. So all those years ago, I had patients who couldn't afford Vivinex Plus is very expensive. Back then, that's all we knew. That's all we had. So they couldn't afford it. So I made a homemade recipe. You can access that on my website. And a lot of people like to do homemade. The main advantage of doing homemade elemental diet is it's less expensive. The other advantage is that people can have control over the ratio of the macronutrients, which is helpful, in toleration. Like sometimes the oils can make people nauseous, sometimes even vomit. And people can be sensitive to the different ingredients. So I've had patients where each time they're dosing it, they try a different oil, like, olive oil, coconut oil, walnut oil, whatever. And they eventually find one they tolerate. That would be an advantage to homemade. Oh, and by the way, I didn't mention the protocol. Sorry. You do that for 2 weeks. You're not eating during it. And the idea here is you're starving the bacteria, but feeding the person, because the nutrients are in pre-digested form. They can absorb right quickly into the person without getting fermented by the bacteria. So quick, right? And the bacteria starve. So it's a different mechanism of action. Dr. Pimentel told me you really need to get to about 10 days to really get those bacteria starved. Sometimes people it's a rough treatment because it's a form of fasting in a way, because you're not eating and, you're just drinking your meals, and it does require a mindset and a mental preparation as well as, physical preparation. Some people can't make it, or it bothers them too much. They don't tolerate it and they stop after a certain amount of days. I just think, well, look, any amount is better than none. We still got some bacteria down, so we'll take what we can get. And the protocol is that at the end of 14 days, you would do a retest with the intention to check to see if it's gone. And if it's not gone, you would then continue. You'd want to get your result quickly, if possible. And then you'd continue for a 3rd week if it wasn't gone. Now, logistically, this might not be possible with how quick you can get test results back. If a person's up for it, I suppose they could just keep continuing the elemental diet until you get the results back. Many people, though, are not willing to do a 3rd week. So 2 weeks is all they were going to do anyway. So if it's not cleared, you're going to have to move on to another treatment. So I just spoke so long. Oh my God.
No, that was great. Awesome. I know we're almost out of time, but I wonder if it's possible, maybe briefly, if you could touch 2 more subjects. One would be motility agents and 2 would be probiotics.
Sure. So motility agents, these are prokinetics. Prokinetics, I think, are essential in SIBO treatment. There's 2 places I use them. After you treat someone with the antimicrobial treatment, pharmaceutical or herbal antibiotics or elemental diet. When you finish the course, it's recommended to put someone on a prokinetic, presumptively, to help prevent backsliding, because so many people need multiple rounds of treatment before they're going to be done. You're in the middle of treatment. I've already explained why we don't just keep someone on the herbals or the antibiotics forever. I would if it would work, but they start already relapsing. So they have to come off. It's time to assess, retest, and assess. During this period, you put them on a prokinetic so they don't backslide. Now, they probably will backslide anyway, but at least you're doing something to help slow that backslide down. Now, the second place you use them is when you're all done. You've achieved your result. They're either 90% better in symptoms or there's a negative test. And so you're done. And you put them on the prokinetic to help them not have a relapse.
And you never do the prokinetic at the same time as the treatment?
You can. Prokinetics offer symptomatic relief depending upon the dose and when you dose it. So there's no harm in that. It's just that you don't need to have them on it during the treatment. People ask this all the time. So I didn't mention our prokinetics, but one of them is LDN. Now, LDN is not technically a prokinetic, but it does have prokinetic activity. In studies, it is shown to have prokinetic activity. It isn't a prokinetic, though. But we use it as such. And I would say that in a certain proportion of people, it just doesn't work like a prokinetic, like, I don't know, at least a third. And then in 2/3 of people, it might be great. Well, anyway, most of us know that LDN can cause sleeping disturbance. And so what we often do is we start it low and titrate up over time. Well, because of that, if you're using LDN for your prokinetic, once you've gotten someone titrated up, you don't then want to stop it if you're going to do another round. That doesn't make sense. So you would continue the LDN through the next treatment round. Now, the other prokinetics are that's pharmaceutical. Prucalopride, which finally came to our country, and it's called Motegrity, but in other countries, it's called Resilor or Resitran. And honestly, most people are still getting it through Canadian pharmacies because it's such a hassle to get it approved by somebody's insurance. Some insurance plans cover it, others don't, right? So, because it's new. Prucalopride is really very excellent. It's a very effective prokinetic. It's very safe because it's a highly selective one. The dose is 0.5 milligram at night before bed to stimulate the migrating motor complex at night when we're sleeping, when we're fasting. I didn't mention the dose of LDN. For diarrhea, it's 2.5 milligrams, diarrhea patients. For constipation patients, it's 4.5 or 5 milligrams. That's set by Dr. Weinstock. The third pharmaceutical option we have is low-dose erythromycin. Erythromycin is an antibiotic, but it's famous that in low dose, it is a prokinetic. It's a first-line therapy for gastroparesis. It's the reason why many of our patients, when they take erythromycin or azithromycin, a Z-Pak, get diarrhea because it's at such a high dose. It's also affecting the large intestine. But at low dose, it usually does not cause diarrhea. So the dose is about 50 milligrams. You can cut a pill. So you can cut the pill into quarters. A 250 milligram pill can be cut into quarters, 62.5 milligrams at night before bed. By the way, pharmacists will tell you you can't cut the pill, but you can. It's okay for this purpose. Now, we have herbal options as well. We really have two things. We have Iberogast, which is a famous German herbal combination formula that's kind of like their Pepto-Bismol. It's like the medicine cabinet digestive tonic. It's been studied for like every symptom you can imagine, and it also went head-to-head against 2 pharmaceutical prokinetics for dyspepsia, for gastroparesis, and it was found to be more effective. So it does have prokinetic activity. We get it from Amazon usually. There's been issues with sourcing, but that's usually where we get it from. And then there's ginger root. Ginger root in about 1,000 milligrams at night before bed. And then what we have is we have all these supplement companies that now make ginger-containing prokinetic formulas. So we have Modal Pro, Motility Activator, Sibo MMC, Prokine. There's another new one. I keep forgetting its name. I've advertised it in my newsletter, but it's like I can't remember. So we have all of these ginger-containing prokinetics, and so they all have ginger, and then they sometimes have artichoke leaf, which actually is a high fermentable, but it's in a small, imagine the pill size we're having here. It's very small, and they'll have 5-HTP, and they'll have other ingredients like that. So any of these are fine. Again, they're all used at night before bed to stimulate the migrating motor complex. For all of these ginger-containing prokinetic formulas, we usually use 2 or 3 capsules at night before bed. Now, if you're going for symptomatic relief, you use them in the day. If somebody has gastroparesis, you use them before they eat. If somebody has bloating after meals, you use them with or after a meal for symptomatic relief. Now, last one. Oh my gosh, you must be so sick of hearing me talk. Probiotics. So probiotics are controversial in SIBO because people are worried that if you just take more bacteria, if you have an obstruction down in your small intestine, if you have slow motility in your small intestine, won't these bacteria just add to the overgrowth? You're just adding more bacteria down there. Valid concern. The interesting thing is that probiotics have been studied specifically for SIBO a lot. We have like 35 studies on probiotics and SIBO. We have a meta-analysis with 22 studies. And all of them either show favorable outcome or certainly no harm. Now, this is where it gets really interesting because there's a disconnect. The studies are good, but so many patients respond poorly to probiotics. And specifically, they seem to worsen some of their symptoms, most often bloating. I think this is probably due to cross-feeding because probiotics make acids that then other bacteria turn into gas. And so I think inadvertently, they can feed gas. They don't make it, but they could help create it. But at the same time, often when someone's bloating gets worse, we'll see either their constipation or diarrhea get better, right? I don't know how many of you seen this. I see this with so many things. It's like there's a benefit from something you're giving and a detriment, and you just have to decide what's more important. So this is really frustrating. So I still think it's a great idea to try probiotics with our patients to see if they tolerate them. What I do is I ask people, how have you tolerated probiotics, while you've had your SIBO? If they've never tried them, then we try them. And I always use them without prebiotics because prebiotics are there to feed the bacteria and they can aggravate symptoms. Now, it's not like fiber or prebiotics are illegal in my mind for SIBO. It's just proceed with caution, start low, and maybe at first don't use them, Go ahead.
Yeah, I asked Dr. Pimentel about aren't there a lot of studies that show benefits of probiotics? And he said, you really can't see these studies as valid because they're all using different particular strains and combinations of strains. And, that's not the way you do a study. Nobody would just say, well, we'll just take any kind of antibiotic of whatever dosage or whatever type. And there I have a good study.
He's absolutely right. There has not been one single duplication study, and they're usually all in small numbers, and they're very often in very specific underlying conditions, like short bowel syndrome in children, things like this. Some of them don't specify the strain. It's like they're like lactobacillus species. It's like, okay, all right, So I still think, when you look at all the mechanisms of actions of probiotics, they make antibiotics, right? They make bacteriocins and defensins. They have, at least in some studies, that shown to stimulate motility either directly of the MMC or through short chain fatty acid production. They have all these, they lower inflammatory cytokines, they do all these beneficial things. So I really think it's okay to try them. Now, in the past, Dr. Pimentel was not in favor of them, and he had a belief, which I don't know where he's at with it now, that you can't even get someone better if you give them probiotics or food that has probiotics. Now, I didn't have that experience because as a naturopath, my training was to give everybody with digestive problems probiotics. So myself and my colleagues did that to all of our SIBO patients in the beginning, and we had lots of success. But here's what's really interesting. When I heard Dr. Pimentel say he was against them, I thought, well, let me stop giving probiotics to patients and see what happens. And honestly, it was a little better in terms of symptoms. It was a little better to not give them. Now, I still use them, but what I do is I just go by the individual. How have probiotics affected you? And if somebody's like, they're horrible, I don't go there. If they're like, oh, they help me, great. Why would you not use that? It's working for them. So I just do it by the individual. I don't base it on the condition of SIBO.
Allison, thank you. Thank you so much for giving us so much time. It was incredible.
You're welcome, but I haven't even answered all these questions. I feel so bad.
No, that's okay. This was great.
Well, you're welcome. And by the way, for anyone who wants more, Ben said to me today, we should offer everybody a coupon code. Please give Ben credit. it was him asking me, I'm sorry, I didn't think of it myself. So we did make a coupon code if anybody wants more, $700 off of my pro course. I mean, it's a crazy time. I don't know if anybody feels comfortable purchasing much of anything.
And use the code Ben, right?
Use the code Ben. Yeah,
okay.
So you can just find that through my website. And anyway, I really wish I had a chance to answer more of your questions and also hear from you all. I just have a feeling you're like the best people in the world, and I want to know you all. So hopefully I'll have more time for that later.
Thank you. Good night, everybody. Thank you for all joining.
Good night.